Okay, so the 4 guidelines that I focused on were all guidelines that show us or tell us how to treat early breast cancer. They aren't specifically just dedicated to radiotherapy. They are early breast cancer guidelines, and within them, there's a mention of how the radiation should be done or indications for radiotherapy. The specific delineation guidelines are presented, or rather published by ESTRO, ASTRO, and the RTOG. So those are atlases that the oncologists can look at for different delineations. The first one that I'm looking at for every topic is the St. Gallen guideline, which are early breast cancer guidelines. These are published every 2 years after the St. Gallen conference, which takes place in March. Then the ESMO guidelines, these were most recently published in 2019, and these are updated every few years. The NCCN guidelines are the American guidelines, and these are really great because they're updated frequently throughout each year, so they really are dynamic guidelines. And then the NICE guidelines, which are published in the UK, they are cost-benefit guidelines. So they very much also take the financial aspect into consideration, which is a helpful thing. And these were last published in 2018, and prior to that, they were published in 2009. I've looked at adjuvant treatment in the following situations, which very much follows Tubile's talk, and we'll get started. So the first topic is DCIS. The DCIS, the St. Gallen guideline, and the majority of guidelines agree that hypofractionated radiotherapy is acceptable. The fractionation schedules that they recommend are 15 or 16 fractions, and they generally all agree that radiotherapy can be avoided post-breast conservation surgery in DCIS in low-risk patients. A boost should be added to patients, they suggest, who have got a less than 2 millimeter surgical margin, if there's the presence of comedonal necrosis or if there's large areas of DCIS. And it is also noted that there is no overall survival data for this, and there's no actual randomized data for patients with DCIS, but definitely boosts are recommended. Radiotherapy can be avoided in patients who are older than 70 years with low recurrence risk features, which very much falls into a similar group, which we'll discuss a bit later, the invasive breast cancer group. The ESMO guideline agrees with the St. Gallen guideline, and they consider omitting radiotherapy in low-risk patients, which they've classified as DCIS less than 10 millimeters, low grade, also with adequate margins. The one caveat that they have is that pleomorphic lobular intraepithelial neoplasia should be treated as per high-grade DCIS, and they also consider a boost in patients at higher risk for local failure, and suggest that we don't use post-mastectomy radiotherapy, which is in line with what we do. The NICE guidelines also suggest considering radiotherapy and are very brief and to the point. And the NCCN guidelines recommend adjuvant radiotherapy. They actually suggest that all patients benefit from radiotherapy, and there's data to show that low-risk patients potentially have later recurrences. There was also recently a population-based study that was published in the Journal of Clinical Oncology, which showed a modest overall survival benefit in high-risk DCIS patients, so patients who are younger with high-grade DCIS and a bigger tumor. And they also suggest the addition of a boost is patient-specific, and that in all patients, however, it does decrease the local regional recurrence rate. So in conclusion, the majority of the patients post-breast conserving surgery for DCIS should have whole breast radiotherapy, considering omission really only in low-risk patients. There's no radiotherapy post-mastectomy, and a boost should be considered when margins are less than 2 millimeters, if there is comedonal necrosis present on histology, and for larger tumors. Moving on to post-lumpectomy, as well as sentinel lymph node biopsy, the St. Gallen guideline states that moderately hyperfractionated radiotherapy regimen is now standard of care, regardless of the patient's age. This is in agreement with the ESMO guideline. And the ESMO guideline then goes on to discuss the sentinel lymph node biopsy, much of what Tobile has discussed with us. They also say that the patients with micrometastatic disease in their nodes require no further auxiliary treatment. Patients with 1 to 2 nodes positive can either have part of the axilla treated with high tangential breast beams, according to the ACSOG Z11 trial, or have auxiliary radiotherapy, which falls under the Amoros trial. The Amoros trial, they delineated all the auxiliary levels, so include level 1 to 3, as well as including the supraclavicular area, and treated the whole region. The NICE guidelines agree that you should be hypofractionating your patients and should use external beam radiotherapy, also giving 40 gray in 15 fractions. They also say this after mastectomy, and we're going to get to that a bit later. And then the NCCN guidelines agrees with the hypofractionated approach. They do state, though, in selected patients, you can use conventional radiotherapy. Just for the non-oncologists, radiation oncologists, hypofractionated radiotherapy is anything where we give more than 2 gray per fraction. So there's different treatment options that you can use, and all the trials seem to have different fractionation schedules, but that's just important to know, and that's what we're talking about when we say hypofractionated treatment. So in conclusion, for that topic, all guidelines recommend moderately hypofractionated radiotherapy post-breast conserving surgery for invasive breast cancer. Now, something that might be a bit unclear is when patients should have a boost included. And I think it's not always clear to everyone who should get a boost because the guidelines don't all agree. It does seem that boosts are favored more than not favored, and we're going to talk about that now. Especially in high-risk patients. So the St. Gallen guideline recommends them for high-grade tumors, for patients with extensive DCIS and patients who are younger than 50 years, as well as for HER2-positive and triple-negative breast cancer subtypes. The ESMO guidelines suggest the same first 3 characteristics, and then also includes focal positive margin and lymphovascular invasion that's present. The NICE guidelines just suggest that it should be used in patients who are at high risk for local recurrence. And the NCCN guidelines have similar high-risk characteristics of patients being less than 50 years of age, grade 3, with a focal positive margin. Other guidelines that I haven't quoted include patients up to the age of 60 years. And NCCN guidelines recommend that patients get 10 to 16 gray in 4 to 8 fractions as their treatment. You can just see below on the image, there's a picture of a boost that's being treated within the breast. So there are pros and cons to boost addition. It improves the local regional recurrence across all age groups. This does seem to decrease with age, and mostly patients younger than 50 years have a larger absolute local regional recurrence benefit. But everyone does get a benefit. And with improved planning techniques, we have improved dose conformity, which decreases the cons or the negatives. One of the negatives is that patients feel that they sometimes have worse cosmesis in the long term because you're giving more radiotherapy to the breast. And the other issue is that it can increase the cost, which can be an issue where resources are constrained. In the same mini review article that was published in Frontiers in Oncology in June 2020, does seem that with hyperfractionation internationally, that doctors are maybe using less boosts. And we'll see how that goes in the future as we start perhaps to hyperfractionate more. Doesn't mean patients don't require boosts, it just seems to be a trend that seems to be observed. So as a summary of who you should consider a boost in, any patient who's had breast conservation therapy, who's high grade, younger than 50, has had an incomplete response to neoadjuvant chemotherapy, has had extensive DCIS, has a focal positive margin, is lymphovascular invasion, or the HER2 or triple negative breast cancer subtypes. Partial breast irradiation is advocated in some guidelines, and in other guidelines, including the St. Gallen and the NCCN guideline, they suggest it's predominantly investigational still, and caution should be used against the routine use of this. I think as more data and more long-term data is published, I think this will be more used in certain patients. All the patients that are suggested across all 4 guidelines that we should consider partial breast irradiation for do not include young patients. It should be avoided in patients with lobular breast cancers and patients with hereditary cancer syndromes. Then the guidelines deviate slightly. If patients have got lymphovascular invasion, it should not be done. It's mostly done in patients, it must be done in patients who have got clear margins, who are stage 1, who are estrogen receptor positive, and are willing to take endocrine treatment. And that is across the board. Generally, you have to meet all the criteria per guideline, whichever guideline you use, to consider using partial breast irradiation. In the NCCN guideline, they're even stricter, and they say patients must be older than 60 years of age. And they've given 2 options that you can use, either 34 gray in 10 fractions treated twice a day with brachytherapy, or 38.5 gray in 10 fractions treated twice a day with external beam radiotherapy. And that looks much like a boost volume, almost, which you can see in this picture. Moving on to post-mastectomy radiotherapy, we often discuss this in our combined meeting, and the big question is whether we should be hypofractionating these patients or offering them the conventional 5-week radiotherapy treatment. The St. Gallen guideline suggests in the most recent publication, and the one that I've used was actually the pre-proof that before it's been published properly in the journal after the most recent St. Gallen conference this year, March. And they suggest that moderately hypofractionated radiotherapy should be used for all ages of patients using a 15 or 16 fraction regimen. The ESMO guideline also gives the indications where they use post-mastectomy radiotherapy, which Tabile has kindly taken us through, so I won't go through it again. But they suggest that hypofractionated radiotherapy is recommended also in all patients, but that we should have close follow-up of younger patients, patients post-mastectomy, and patients for regional nodal radiotherapy. And they do say that it is lacking long-term follow-up data. The NICE guidelines also use a hypofractionated approach for post-mastectomy radiotherapy, giving 40 gray in 15 fractions for any post-surgical breast cancer patients. And they also say that we should avoid post-mastectomy radiotherapy for patients at low risk for recurrence, and give the same indications of node-positive breast cancer, involved resection margins, and considering patients with bigger primary tumors upfront, even if they are node-negative. The NCCN guidelines are the most conservative with regards to the recommendation of the dose that should be given, and they still recommend 46 to 50 gray in 23 to 25 fractions. They suggest that in specific patients, you can boost the scar to a total dose of 60 gray, and I'm sure that's with positive margins. And they also recommend to use post-mastectomy radiotherapy in all node-positive patients. And in patients who are node-negative with the tumor that's bigger than 5 centimeters, so fitting into the T3, T4 category, or patients with positive margins or less than 1 millimeter margins. They also suggest that you can consider post-mastectomy radiotherapy in patients who are high risk for recurrence and node-negative. And the high risk for recurrence features they would look for are premenopausal patients with lymphovascular invasion, close margins, and a tumor bigger than 2 centimeters in size, which is considered a slightly larger tumor. They also say that you can consider it in node-negative, triple-negative breast cancer patients with tumors smaller than 4 centimeters. So in conclusion, which is different to what we are used to perhaps, is that the majority of guidelines advocate moderately hypofractionated regimens, but they all suggest that we might need longer follow-up data. Definite indications for post-mastectomy radiotherapy is N2 disease, which is more than or equal to 4 nodes that are positive. N1 disease, which is 1 to 3 nodes with high risk features. T3 or T4 tumors and positive margins. It can be considered in patients at higher risk for recurrence with N0 disease or no nodes that are positive, and this includes triple-negative breast cancer patients who are premenopausal, lymphovascular invasion is present, a tumor that's bigger than 2 centimeters, and close margins. So the big debate between hyperfractionation versus conventional fractionation currently stands at the available data shows the same local recurrence rates, disease-free survival rates, and overall survival rates at 5-year follow-up. 5-year follow-up is very short in the lifetime of an adjuvant breast cancer patient, and particularly as we are getting much better at treating these patients. The benefit of hypofractionating is that there's less cost with hypofractionation and there's more accessibility where access is limited. It's also been shown there were 5 retrospective studies which have looked at post-mastectomy radiotherapy, including hypofractionated regimens. There seems to be fewer acute skin reactions, as well as a relatively recently published Chinese phase 3 trial, which is the biggest current trial that we have using hypofractionation in post-mastectomy patients. The biggest concern is that whether the data currently is robust enough and whether we have enough long-term data. And the other thing that we always wonder about, which can be seen almost separately to post-mastectomy radiotherapy, but is mostly included, or can often be included in patients who get post-mastectomy radiotherapy, is regional nodal radiotherapy. And the concern that we often voice at our combined meeting is the risk of brachial plexopathy and hypofractionating these patients. I'm going to tell you now what the data says currently. Prior to that, just quickly looking at patients who are post-reconstruction, post-mastectomy, and what we should be doing for them. The St. Gallen guideline still recommends moderately hypofractionated radiotherapy for these patients. The ESMO guideline and NCCN guideline don't state much about dose. They just say that patients can receive radiotherapy if they have an immediate reconstruction. Alternatively, which frequently happens with our patients, is an expander is placed at mastectomy, then the patient finishes their treatment, including their radiation, and then only later an implant is inserted, and they agree with that approach. There are 2 trials that are currently ongoing, however, which will maybe give us more information about that. The RT-CHARM trial, and the first analysis will be in October 2021, as well as the Fabric trial. And both of these are comparing patients post-mastectomy having radiotherapy, and one group is having hypofractionated treatment of 15 fractions, and the other group is having conventional radiotherapy. And then we will look at the long-term cosmetic outcomes. The issue is that the first analysis is in October 2021, but the final analysis will be in 2035. So we have a long time to wait to get the final data. Looking at regional nodal radiation, and then I'm going to go through the hypofractionations versus conventional fractionation debate. The St. Gallen guideline suggests that we should not be using regional nodal radiation in pathological T2N0 patients, even if they require breast or chest wall radiotherapy. It should also not be included for patients who are triple negative or HER2 positive clinical T2N0 patients who've had a pathological complete response post-neoadjuvant chemotherapy. It should definitely be included in patients who clinically have positive nodes upfront, irrespective of the response to neoadjuvant treatment. The ESMO guideline agrees that regional nodal radiation should be given to patients with involved lymph nodes, but the exact volumes are quite poorly defined. For supraclavicular radiation, ESMO generally uses the ESTRO guideline, which Tobele explained follows the blood vessels and is usually a smaller volume versus the RTOG atlas, which is often uses bony landmarks and is often used for more locally advanced breast cancers. After axillary lymph node dissection, they state very clearly that we should not irradiate on operated axilla unless there is residual disease present, and that will show up in the histology report as being extracapsular extension, tumor deposits in the fatty area of the axilla. And another caveat to this is that if patients don't have sufficient nodes taken, or not sufficient nodes taken, but less than 10 lymph nodes resected, and more than 50% of them have disease that is present. The previous St. Gallen guideline also suggested patients with N2 disease, so more than 4 nodes that are positive, you should include the axilla. That wasn't stipulated in this current guideline. If the sentinel lymph node biopsy is positive and the patients do not have an axillary lymph node dissection, regional nodal irradiation should be done. And then the big question is, if you've had an axillary lymph node dissection and you are concerned about patients, which axillary lymph nodes should you include? And that is also stipulated, taking into account the risk features of patients. So in the NICE guidelines, they say you should also avoid regional nodal radiotherapy for clinical node negative disease, as well as pathological node negative disease and after axillary nodal clearance. They include the supraclavicular fossa in patients who've got N2 disease, or patients who have N1 disease with other poor prognostic factors. And they state that we should consider including the internal mammary nodal chain with nodal radiotherapy in patients who are node positive. In patients who are node negative, there's about a 10% risk of an occult metastasis to be present in the internal mammary nodal chain. And in patients who are node positive, it goes up to about 40%. So it is with right-sided breast cancers, it is easier to include the internal mammary nodal chain because you're not concerned about the heart. But in left-sided breast cancers with more advanced planning techniques, this can also possibly be done, and particularly with deep inspiratory breath holding techniques. And there is some survival benefit in some trials to including the internal mammary nodes, particularly in patients who've got a heavy nodal disease burden or patients who've got medial central tumors. So the NCCN guidelines for their regional nodal irradiation, they include all of the nodal levels, the supraclavicular area, the infraclavicular nodes, internal mammary nodes, and clinically suspicious axillary nodal regions. And they state this is category 1 recommendation for more than or equal to 4 nodes, or category 2A in 1 to 3 nodes that are positive. It's not usually recommended in node-negative patients, but it can be considered in patients who have got large tumors or positive margins post-mastectomy. And they put a dosing there as well, once again, using the conventional radiotherapy dosing. So just to look at whether we should be hypofractionating or not, and I think the jury is out. So I'm not saying that this is the way we should go. I think the guidelines themselves are still deciding. Certain guidelines are specific and other guidelines give you us options as the treating oncologists. I took a look at the data that was available for post-mastectomy radiotherapy as well as regional nodal irradiation. And I stated earlier that there were 5 retrospective studies looking at this. But the 4 prospective studies that we have are these 4, the START A and B trials, as well as a phase 3 study that was done and published in China that was completed in 2016, and then a phase 2 study done in the United States that was completed in 2014. And truly what you can see is that the START A and B trials are the only ones that have slightly longer follow-up data versus the other 2. But the minority of the patients were post-mastectomy and the minority of the patients received regional nodal irradiation. In the other 2, they were all post-mastectomy and received regional nodal irradiation. What was clear from these trials, though, is that it appears that the 5-year local regional relapse rate, the distant disease-free survival rate, and the overall survival rate seems to be comparable between conventional radiotherapy and hypofractionation. They all did use different fractionation schedules, which could be problematic. And looking at the side effects, they pretty much had the same amount of grade 3 toxicities in both arms, looking at both of them. But as I said, the Chinese and the US studies haven't had long-term follow-up data yet, other than 5 years. The START A trial did use 2 hyperfractionated regimens, including 39 gray in 13 fractions, or 41.6 gray in 13 fractions, and only the one with the higher dose of 41.6 gray seemed to be equivalent to conventional radiotherapy. We don't really use that in our current hyperfractionation regimens, and it's also not what's advocated in the guidelines. There was 1 patient in the START A trial that developed mild brachial plexopathy, which was then treated. And in all the other studies, that was never shown, that has not happened, including the START B trial, which is predominantly the hyperfractionation regimen that we use, which is 40.05 gray in 15 fractions. Incidentally, there happens to be longer follow-up data as well. In 1997, the British Columbia Canadian group published a trial in the New England Journal of Medicine, and it wasn't actually to assess the toxicities for hyperfractionated radiotherapy. At that point in time, they weren't certain that we should be adding radiotherapy to our breast cancer patients in locally advanced breast cancer. And they looked at patients who had radiotherapy with chemotherapy versus no radiotherapy post-mastectomy for locally advanced breast cancer patients. The patients definitely benefited with the addition of radiation, which is not what we're trying to say here. But what was interesting is that there was no worse toxicity at 15 years, grade 3 toxicity, and especially not in the brachial plexus for these patients, looking at it at 15 years in the patients who received radiotherapy. And they received a regimen of 15 fractions times 2.5 gray, probably using very old planning techniques. And that's very similar to the fractionation schedule that we use these days. Looking at the next topic is older patients and the mission of radiotherapy. So when I wrote my final exams, we learned this, and we kind of stated that these patients we should really avoid radiotherapy in. It's not a blanket statement, and each of the guidelines are quite specific to say we should individualize it per patient. I think it has a lot to do with the fact that patients may have a longer life expectancy these days, and quite a lot of our patients don't necessarily want to go onto endocrine treatment, despite that perhaps being the best option for them. It's quite clear from the guidelines, each guideline on its own has specific things that you should tell your patients with regards to the local or regional recurrence risk, that it's slightly higher in patients if you don't give them radiotherapy. There doesn't appear to be a survival benefit by adding the radiation, but the patients do need to then go onto endocrine treatment for a minimum of 5 years. Most of the patients in all the guidelines that are included for the consideration of the admission of radiotherapy are patients either older than 65 or 70 years They must have stage 1 disease, must be estrogen receptor positive, HER2 negative, and either be less than 2.5 or 3 centimeters, depending on the guideline you look at, must have node negative disease, and they must be compliant on the endocrine treatment. And the NCCN guideline agrees much the same, and it can be considered after discussion with patients, and patients can do well without having radiotherapy. So as my final slide, before we take some questions, is just to look at the possibility of things in the future. Something that's very exciting is genomic signatures that are being used to determine the benefit of radiotherapy. This is not considered standard of care yet in any of the guidelines. The ones that we are waiting for in DCIS, they currently do use Oncotype DCIS, and I found out it costs the same as an Oncotype DX. It is actually being shown to be prognostic rather than predictive, but it does help the radiation oncologist to tell their patients that there may be a very low probability for their DCIS to recur or an invasive breast cancer to recur, and therefore the patients may want to avoid radiotherapy. It is considered better than using the retrospective scores like the Finesse prognostic index, but the issue is that they are expensive, and I don't think they're always going to be funded, as we struggle with Oncotype DX funding still. Another test that we actually don't have in South Africa, which is a predictive test, and maybe one day it will come, is called the Decision RT test, and that does definitely tell you which patients will benefit from radiotherapy and which ones will not. So that could be very helpful. And invasive breast cancer, we are still waiting, as Tabile said, for the Taylor RT trial. There are a few other prospective studies ongoing at the moment, but unfortunately we don't always have access to all those genomic signatures in South Africa like the PAM50. Also, there's a growing interest in ultra-hyperfractionated radiotherapy regimens, which Tabile mentioned. These are still not considered standard of care. They were brought out originally because of COVID, and I'm sure most of you have heard of the Fast Forward trial, which was started in the UK. The NCCN says you can consider it. The issue is that there's no leg toxicity data beyond 10 years, and we know that these patients live for a long time. And also, we're unsure of what boost regimen to use with ultra-hyperfractionated radiotherapy. Something that I find interesting that may be something of the future is preoperative radiotherapy, which is not where we're at yet. That's very much in the phase 1 trial development still. But I think that the majority of patients in the next few years will be treated with moderately hyperfractionated radiotherapy regimens, post-surgery, post-breast conservation surgery, post-mastectomy, and probably for regional nodal irradiation, because we've gotten so much better at using different radiotherapy techniques to improve the heart and the lung sparing, and allowing us to increase the therapeutic ratio, which is what we're always trying to get to as radiation oncologists. Thank you, everyone, for your time.
Thank you very much. That was a very comprehensive review of all the guidelines. I wonder if Tabile can join us as well, because the first question in the chat function is actually addressed to Tabile, and it's from Solomon, and it says, "Thank you, Dr. Golba, for an excellent presentation," which I totally agree with. What is your comment on hyperfractionation during boost?
So the studies that looked at hypofractionation did in fact give a boost to their patients. I will comment on the START B in particular, where they use 10 gray boost in 5 fractions. So we can use boost, but as Heidi mentioned, with the ultrafractionation, it's not standard of care as yet, and we're not sure what boost dose we would use. So I think for the hypofractionation of 40.05 to 42.5, we can add a boost, but I would be reluctant with the ultra hypofractionation because we actually are not sure how those patients would do with that boost.
Okay, thank you. Heidi, I've got a couple of questions for you from myself. You quoted the Z11 trial, and the Z11 trial gave us no details whatsoever about the radiotherapy fields for nearly half the patients. How can you deduce anything about radiotherapy fields from that trial?
So I looked at the data again, and sometimes the supplementary data tells you what they've used for the radiation fields. They did include the supraclav in 19% of those patients. So the Z11 trial, there's lots of controversies around it. The one is that they included the supraclavicular area for 19% of the patients. The other thing is it was quite clear from the data that they used high tangential fields. And if we do that, which is what we used to do before we had fancy planning techniques, and we did markups on the simulator, we used to match the tangential field field below the humeral head and then let it match to the medial the supraclav border matched medially to the medial, laterally to the medial humeral head, and the two fields would match. And that used to include level 1 and most of level 2 of the axilla. And that's pretty much what they did with the Z11 trial. The other issue with the Z11 trial is that 60% of the patients continued on to have systemic treatment, which could obviously also affect the outcomes.
Okay. There are two comments I'd like to pose to you, Heidi. Sorry, I'm really targeting you now.
If I can answer them.
Oh, absolutely, absolutely. The Association of Breast Surgeons had their conference recently. That's the English group, and there were two things out of there that I would like to draw, comment on. One is they said, and I'm going to ask you the question. Is it ethical if somebody has early breast cancer and is suitable for a tumor excision radiotherapy to offer them a mastectomy? And there was a whole debate about it for 2 hours, because we know the survival is better if you have a tumor excision and radiotherapy. So should we be offering them a mastectomy, or do you think we're going to end up offering all these patients radiotherapy even if they have a mastectomy?
No, so I don't think we're going to offer everyone radiotherapy if they have a mastectomy, to answer that question. I think that patients do seem to do better with breast conservation therapy in early breast cancers. So patients who wouldn't have radiotherapy up front. So I think it's important that everyone discusses their patients in a combined meeting. Even if you can't have a meeting where everyone sits together, we've now gotten used to using Zoom, and actually we can do all Africa NBTs if that is what it takes. I think it's important that people can speak to so that the surgeons are aware of who is going to get radiotherapy up front, because we discussed it in our combined meeting. The patients come with an idea, and then the surgeons and the oncologists discuss together what the best operation type would be. And if patients then still want to go ahead with a mastectomy, that's fine, but understanding which patients will have radiotherapy up front I think is important before you make the surgical decision. You can only really do that in the combined meeting because it's a lot of information, and I can't do what the surgeons do. So it's nice to have an oncologist to help you with the decision.
Okay. All right. Just to brag about our Tigerberg MDT, which also Tabile is part of, we do actually have Zimbabwe joining us, as well as Western and Esther River. So there you go. So well, yes, we do know the benefits of that. Okay. I see there are two new messages. So before I ask mine, question for Heidi. Since the COVID pandemic, we as surgeons have been only too happy to send basal cell and HER2 positive node negative for neoadjuvant chemo. Would you prefer sentinel node biopsy before or after the chemo?
No, so that's a very good question, because this has recently changed, I think, from everything that I've read. We prefer not to have sentinel nodal biopsies before the chemotherapy because the patient has to have 2 anesthetics. What is quite clear, though, is that you please need to do an axillary ultrasound, because we want to know if there's any disease up front. And if there's anything that they're worried about on the axillary ultrasound, a biopsy must please be done, and clips should be left in the nodes that they are concerned about. Obviously, if a patient has very heavy nodal positive disease up front and clinically looks like there's a lot of nodes, then the patient is not going to be a candidate for a sentinel lymph node biopsy despite neoadjuvant chemo usually. So then it's not necessary to clip everything. But if there's 1 or 2 nodes that are worrying, a biopsy and a clip is great. And then the sentinel lymph node biopsy can be done after chemo.
I think, Linda, the answer to your question is that it shouldn't just be a clinical diagnosis for the node negative status. It must be a good ultrasound diagnosis as well for the radiological diagnosis. Okay, I'm going to ask one last question and then we're going to move on to the next section. And you mentioned age. Again, from the ABS conference, they said, and I want to know if you agree with this, that what you should do is you should look at biology, stage, and age last. Do you think it's time we dropped age from the guidelines and just looked at comorbid factors?
Yes, I totally do. And I think the guidelines, I think that's what's happened. So when I qualified in 2016, we decided everyone over 70, we won't offer them radiotherapy. And that's very much it. The guidelines may not have stated it so clearly, but very much in my mind, looking at the guidelines again and discussing it in our combined meeting, we are definitely not ageist, and we actually look at the patient and discuss it with the patient, which is important. Some people want to live to 100 and have the capacity to do that. So the guidelines actually state, as some of them state, that if patients aren't going to live for 10 years, so that means someone who's 40 who has many comorbidities, or someone who is 100, maybe with no comorbidities.
Okay, fantastic. So we have a quick a moment for Tabile to add any other comments to those questions that I haven't targeted Heidi with, or if she'd like to say anything else.
No, I think I concur what you've just said with regards to the age, because we always are debating that in our MDT with Dr. Edge. And often when the patients do come to us, they're actually looking quite well in the 70 odd years, and they do well on the treatment, as long as we make sure that we check everything in terms of the ejection fraction, monitor it halfway through their chemo, assess them when they are on their radiotherapy. I think they should get a fair chance of treatment because they do live long.
Jenny, sorry, can I just quickly add one thing? For the radiation oncologists that are online, for those of you that wish to hypofractionate your patients, it is sometimes an issue getting dose constraints for the normal tissues. So a very good website to use, which is free, is something called econtour.org. And on there, you get different volumes that have been drawn. And if you go look at it, you can actually do it for all your radiotherapy. They update it regularly, and it's run by the MD Anderson Cancer Center. And they use all the constraints from the RTOG 1005 trial, where they looked at many different regimens. So that's helpful just for your planning purposes if you wish to hypofractionate your patients. Sorry, Jenny, that's